Welcome. My name is Dr. David Averbach, and today we will discuss the best treatment options for respiratory conditions that appear on steps 1, 2, and 3, the clinical shelf exams, and family medicine, internal medicine, and pediatric boards. This is the second of two lectures on this topic. In the first lecture, we discussed treatment of obstructive lung diseases, including COPD, asthma, bronchiectasis, cystic fibrosis, and obstructive sleep apnea. We also discussed restrictive lung diseases, pulmonary hypertension, and lung cancer. In this lecture, we will discuss treatments for upper and lower respiratory tract infections, ARDS, congenital respiratory malformations and respiratory distress in the newborn, pulmonary embolism, pleural effusion, pneumothorax, and lung abscess. Let's discuss upper respiratory tract infections. These involve infections at or above the vocal cords. They include the nasal cavity, sinuses, pharynx, and larynx. Most of these infections are caused by viruses, but there are some bacterial etiologies. We will begin with acute infections of the nasal cavity and paranasal sinuses. What are the most common organisms? Viruses are the most common cause, and rhinovirus is most frequent. Other organisms include influenza virus, RSV, coronavirus, adenovirus, and human metapneumovirus. Name some bacterial causes of sinus infections. Bacterial causes are less frequent, and infections often follow a viral infection. The most common bacterial cause is Strep pneumoniae. Haemophilus influenza is the second most common, followed by Moraxella. Staph aureus, an anaerobic bacteria, can cause chronic sinusitis. Name some fungal causes of sinus infections. Fungal infections are more common in immunocompromised patients. These include Aspergillus and Mucormycetes. What is the treatment for acute rhinosinusitis? Acute viral sinusitis is self-limiting, and symptoms can be treated with saline irrigation, decongestants, and intranasal steroids such as fluticasone or budesonide. Acute bacterial sinusitis can be treated with amoxicillin or amoxicillin clavulanic acid. If the patient has a penicillin allergy, clindamycin plus a cephalosporin can be used. What are indications for surgery for acute rhinosinusitis? Indications include failure of medical treatment or structural defects such as polyps or a deviated septum. The surgery will open and drain the sinuses. Surgery also needs to be performed for invasive fungal sinusitis, including surgical debridement of necrotic tissue. What is the treatment for chronic rhinosinusitis? Symptoms can be treated with saline irrigation and intranasal steroids. Oral antibiotics should only be given for acute exacerbations. Let's discuss acute tonsillitis and pharyngitis. What are the most common causative organisms? Viruses are the most common etiology in both adults and children, including Epstein-Barr virus, adenovirus, rhinovirus, influenza, and coronaviruses. The most common bacteria is group A strep. What is the treatment for acute tonsillitis and pharyngitis? If the rapid strep test or throat culture is positive for group A strep, treat the patient with antibiotics. Antibiotics include penicillin V or amoxicillin. If the patient has a penicillin allergy, cephalexin can be used if the allergy is mild, or erythromycin can be used if the allergy is more severe. Viral infections are treated with supportive care. If you inappropriately treat Epstein-Barr virus with amoxicillin, it can cause a maculopapular rash. What are the indications for a tonsillectomy? Indications include patients who have recurrent infections or chronic tonsillitis, who can't take antibiotics due to intolerance or allergies, who have tonsillar enlargement causing obstructive sleep apnea, or who have developed a peritonsillar abscess. Let's discuss acute laryngitis. What are the most common organisms causing this? Viruses are the most common cause, including rhinovirus, adenovirus, and influenza. Bacterial laryngitis most commonly caused by a superinfection following a viral infection, usually strep pneumoniae. Haemophilus and Moraxella can also cause laryngitis. How do you treat acute laryngitis? Treatment is with supportive care. Antibiotics can be used if a bacterial infection is confirmed, but they have not been shown to improve symptoms or outcomes of acute laryngitis. Let's discuss some other infections of the upper respiratory tract, including epiglottitis, diphtheria, and laryngotracheitis, or croup. What is the most common organism causing epiglottitis? In an unvaccinated patient, the most common cause is Haemophilus influenza B. In vaccinated patients, including adults and children, the most common causes are streptococcal species, Staph aureus, and non-typable Haemophilus. How do we manage epiglottitis? Endotracheal intubation is often needed in children, and indications include respiratory distress, altered mental status, stridor, and drooling. The patient should receive IV antibiotics that cover the most common organisms, and options include third-generation cephalosporin, such as ceftriaxone, or a beta-lactam with beta-lactamase inhibitor, such as ampicillin sulbactam or amoxicillin clavulanic acid. Let's discuss diphtheria. Diphtheria causes gray pseudomembranes to form over the tonsils, pharynx, or larynx. What is the organism that causes diphtheria, and how do we manage it? It is caused by the gram-positive rod, Corynebacterium diphtheria, and many of the signs and symptoms are due to its exotoxin. Treatment is with penicillin G or erythromycin and administration of diphtheria antitoxin. Let's discuss croup. Croup most commonly affects the larynx and subglottic area, but can also affect the trachea and bronchi. What is the most common organism that causes croup, and how do we manage it? Croup, or laryngotracheobronchitis, is most commonly caused by the parainfluenza virus, and it involves inflammation of the larynx and trachea. All patients should receive dexamethasone to reduce airway inflammation. For moderate to severe croup with dyspnea, resting stridor, or hypoxemia, nebulized racemic epinephrine should be added. Let's discuss lower respiratory tract infections. Let's start with acute bronchitis. What are the most common organisms causing this? More than 90% of cases are caused by viruses when an upper respiratory viral infection spreads to the bronchi. The most common viruses are influenza, rhinovirus, parainfluenza, and adenovirus. Bacterial causes of acute bronchitis include Mycoplasma pneumoniae, Chlamydia pneumoniae, and Bordetella pertussis. Patients with chronic lung disease can get bronchitis from Strep pneumoniae and Haemophilus. How do we treat acute bronchitis? Acute bronchitis is self-limiting. Symptoms are treated with acetaminophen or NSAIDs. Antibiotics are only used if there is a bacterial cause and if the patient is older and at risk for developing pneumonia from the bronchitis. Let's discuss pertussis. Pertussis toxins damage cilia and cause inflammation in the trachea and bronchi. How do we treat pertussis? Pertussis is caused by the gram-negative Coccobacillus Bordetella pertussis. Treatment is with a macrolide like azithromycin to reduce the cough and stop the spread. We do not treat the disease with antitoxin. Let's discuss bronchiolitis. What are the main organisms causing bronchiolitis, and how do we treat it? Bronchiolitis is caused by the respiratory syncytial virus. Treatment is supportive, ensuring adequate hydration. If a patient has signs of hypoxemia, provide oxygen via nasal cannula. Nasal suction is performed to remove mucus from nasal passages, and this is associated with a shorter hospital duration. Bronchodilators, steroids, and epinephrine are not used. What is a preventive measure for infants at risk for severe RSV infection? Premature infants and infants with chronic heart and lung disease are at risk for severe infection. The monoclonal antibody palivizumab is used, which stops the virus from spreading between cells. Let's discuss the treatment of pneumonia. We will divide this into community-acquired pneumonia and hospital-acquired pneumonia. Let's start with community-acquired pneumonia, which can further divide into typical and atypical pneumonia. What are the causative organisms of typical pneumonia? Typical pneumonia, which includes lobar and bronchopneumonia, is most commonly caused by strep pneumoniae, but can also be caused by Haemophilus and Moraxella, particularly in patients with COPD. Staph aureus can also cause typical pneumonia, often in patients who just had influenza or in cystic fibrosis. Klebsiella can cause typical pneumonia in alcoholics, diabetics, and immunocompromised patients. What are the causative organisms of atypical pneumonia? Atypical pneumonia is most commonly caused by Mycoplasma pneumoniae and Chlamydia pneumoniae, but can also be caused by Legionella. Viruses such as influenza, RSV, parainfluenza, COVID, CMV, and adenovirus can also cause atypical pneumonia. What is empiric treatment for typical community-acquired pneumonia? Options include amoxicillin. If drug-resistant organisms are suspected, amoxicillin clavulanic acid or a respiratory fluoroquinolone such as levofloxacin can be used. If the patient is hospitalized, ampicillin sulbactam or ceftriaxone will be combined with either a macrolide or fluoroquinolone. Treatment for pneumonia caused by methicillin-sensitive staph includes beta-lactams, such as nafcillin or cefazolin. Treatment for methicillin-resistant staph includes vancomycin or linezolid. Treatment of Klebsiella pneumonia, which has a high mortality rate, includes third-generation cephalosporins or fluoroquinolones. What are the empiric treatment options for atypical community-acquired pneumonia? Beta-lactams like amoxicillin are ineffective against the atypical organisms. A macrolide, such as azithromycin, can be used. Doxycycline or a fluoroquinolone are also options. Empiric treatment with azithromycin can cover many of the organisms, causing both atypical and typical pneumonia. Let's discuss hospital-acquired pneumonia. What are the most common organisms that cause this? The most common organisms that cause hospital-acquired pneumonia are gram-positive cocci, such as Staph aureus and Strep pneumoniae, and gram-negative bacilli, including Pseudomonas, Klebsiella, and E. coli. In ventilator-associated pneumonia, antibiotic-resistant organisms like MRSA, Pseudomonas, and Acinetobacter are more prevalent, particularly if it's late onset, after 96 hours. How do we treat ventilator-associated pneumonia? If the patient is at a low risk for antibiotic resistance, a single agent can be used with anti-pseudomonal activity and coverage against methicillin-sensitive staph, such as cefepime or piperacillin tazobactam. If antibiotic-resistant organisms are suspected, such as Pseudomonas or staph, you use two anti-pseudomonals from different classes, such as cefepime or piperacillin tazobactam, plus a carbapenem. Vancomycin or linezolid is added to cover for MRSA. What are the organisms associated with aspiration pneumonia? The most common organisms in community-acquired aspiration pneumonia are Strep pneumoniae and Haemophilus, along with staph, E. coli, Klebsiella, and various anaerobic bacteria. Common organisms in hospital-acquired aspiration pneumonia include Klebsiella, Pseudomonas, E. coli, and Acinetobacter. What is the treatment for aspiration pneumonia? If the patient is generally healthy, amoxicillin, doxycycline, or a macrolide can be used. If the patient has other comorbidities or alcoholism, a combination of amoxicillin plus a macrolide or doxycycline can be used. If there is a high risk of anaerobic infection, clindamycin and a respiratory fluoroquinolone can be used. For inpatient management, and if the patient was recently hospitalized and has a toxic appearance, then in addition to for covering community-acquired pathogens, MRSA, Pseudomonas, and Klebsiella must be covered. A coverage option would be piperacillin tazobactam or a carbapenem plus vancomycin. If the patient has foul-smelling sputum or necrotizing pneumonia, suspect anaerobic bacterial involvement and consider adding clindamycin or metronidazole to this regimen. You must also treat the complications of aspiration pneumonia, including a parapneumonic effusion, empyema, lung abscess, and ARDS. Let's discuss pneumonia in the newborn. What are the most common pathogens and the treatment? The most common pathogens are group B strep and E. coli. Empiric treatment is with ampicillin and gentamicin. Finally, let's discuss pneumonia in immunocompromised patients. What are some causative organisms? The most common organisms causing pneumonia in immunocompromised patients include Pneumocystis jirovecii, Strep pneumoniae, Haemophilus, staph, Pseudomonas, TB, CMV, and rarely cryptococcus. How do you treat pneumocystis pneumonia? Treatment is with TMP-SMX, trimethoprim sulfamethoxazole. Steroids can be added if PaO2 is less than 70 or there is a high AA gradient. What is the treatment for CMV pneumonia? Treatment is with ganciclovir. For resistant CMV, foscarnet or cidofovir can be used. Let's discuss treatment for acute respiratory distress syndrome, ARDS. How do we manage this condition? You treat the hypoxemia using lung protective ventilation to avoid lung injury. This involves measures such as low tidal volumes and plateau pressure limits and PEEP titration. PEEP, positive end expiratory pressure, is used to keep the alveoli inflated at the end of expiration. The severity of ARDS is determined by the PaO2 to FiO2 ratio and is graded as mild, moderate, and severe. For moderate and severe ARDS, where the ratio is low, you can lie the patient in a prone position and use neuromuscular blockers such as cisatracurium. If the patient is refractory to all of these measures, ECMO, or extracorporeal membrane oxygenation, can be used where the patient's blood is passed through a cardiopulmonary bypass machine and oxygenated through gas exchange membranes. You will next treat the underlying cause, which is most commonly sepsis, but also includes trauma, acute pancreatitis, pneumonia, and aspiration. Let's discuss treatment of congenital respiratory disorders. Let's start with disorders of the airway. Name these conditions. Airway disorders include Pierre-Robin sequence, choanal atresia, laryngomalacia, tracheomalacia, and tracheoesophageal fistula. What are the clinical features of Pierre-Robin sequence? Patients with Pierre-Robin sequence have a small jaw and chin and a tongue that is placed further back than normal and can obstruct the airway. Most patients also have a cleft palate. How do we treat this condition? Babies should sleep in the prone position to avoid respiratory obstruction. A surgical procedure may be performed called a mandibular distraction to enlarge the jaw and it help advance the tongue. What are the clinical features of choanal atresia? And how do we treat it? Bilateral choanal atresia involves obstruction of the posterior nasal passage and can present in infants as cyanosis when feeding. It can be a feature of charge syndrome. The treatment is insertion of an oropharyngeal airway temporarily until surgery, where endoscopic resection of the posterior nasal septum will be done. What are the clinical features of laryngomalacia and the treatment? Laryngomalacia is the most common congenital cause of stridor. Abnormal laryngeal cartilage collapses during inspiration and causes airway obstruction. Children can have feeding difficulties and GERD. Mild cases can be managed conservatively and monitored, but severe cases require surgery, a supraglottoplasty to alter malformed structures or remove tissue. What are the clinical features of tracheomalacia and the treatment? Weakened tracheal cartilage causes tracheal collapse during expiration and airway obstruction. It most commonly affects the intrathoracic trachea and causes expiratory stridor. If the tracheomalacia is symptomatic and mild, it is managed conservatively with humidified air and the antimuscarinic ipratropium, and it will usually resolve by age 2 as the tracheal cartilage gets stronger. If it is more severe, CPAP and chest physiotherapy may be needed. Surgical options include tracheostomy or aortopexy to attach the weak section of the trachea to nearby organs to help keep it open. What are the clinical features of esophageal atresia with distal tracheoesophageal fistula and the treatment? The newborn will have choking, drooling, an inability to feed, cyanosis, and possibly signs of aspiration pneumonia. This condition is part of the Vactoral Association. Treatment involves placement of a nasoesophageal tube to suction secretions to prevent aspiration pneumonia and using antibiotics to prevent pneumonia. Surgery is performed in the first 24 hours to reconnect the upper esophageal pouch and lower esophagus. Surgery is also the primary treatment to divide the fistula and close the holes in both the trachea and esophagus. Let's discuss treatment of congenital disorders of the lungs. Name some of these disorders. Transient tachypnea of the newborn, neonatal respiratory distress syndrome, meconium aspiration syndrome, persistent pulmonary hypertension, apnea of prematurity, pulmonary hypoplasia, pneumonia, and bronchopulmonary dysplasia. What is the etiology and treatment of transient tachypnea of the newborn? This most often occurs in a term or near-term infant delivered by C-section before labor. There is failure to clear fetal lung fluid. Treatment is with supportive care, such as oxygen and CPAP, and most cases resolve in 24 to 72 hours as fluid gets absorbed. What is the etiology and treatment of neonatal respiratory distress syndrome? NRDS is the result of surfactant deficiency, most commonly in premature infants. Patients are treated with nasal CPAP and PEEP to prevent alveolar collapse. If respiratory distress continues, patients should be intubated with mechanical ventilation and oxygen should be administered with a target of 90%, which is physiologic in neonates. The newborn should also be administered surfactant via endotracheal tube. What is the etiology and treatment of meconium aspiration syndrome? This occurs when the fetus passes meconium in utero, causing airway obstruction, most commonly in a post-term infant. The infant should be given supplemental oxygen, which reduces the risk of persistent pulmonary hypertension of the newborn, a complication of meconium aspiration. In severe cases, inhaled nitric oxide can be given, as well as surfactant. What is the etiology of persistent pulmonary hypertension of the newborn and the treatment? This results from abnormal prenatal development or postnatal aspiration, adaptation of the pulmonary vasculature. Treatment is with an oxygen and inhaled nitric oxide, which relaxes the pulmonary vasculature. If inhaled nitric oxide isn't effective, other pulmonary vasodilators, such as milrinone, sildenafil, or bosentan can be used. If these measures are unsuccessful, ECMO can be used. Let's discuss pulmonary embolism. We will focus on the management of an embolism of a venous thrombus. How do we treat a confirmed PE? Patients can be stratified into low risk, intermediate risk, and high risk PE. Low risk patients are hemodynamically stable. If these patients don't have any bleeding risks, we will anticoagulate with low molecular weight heparin, such as enoxaparin. If they have a bleeding risk, we can use an IVC filter. High-risk patients are hemodynamically unstable, have elevated troponins, and evidence of right ventricle dysfunction on transthoracic echo or CT pulmonary angiography. In these patients, reperfusion should be initiated with thrombolysis using TPA. If thrombolysis is contraindicated or unsuccessful, catheter-directed thrombolysis should be attempted. If this fails, surgical embolectomy can be performed. How should the patient with a PE be managed after they are discharged? The patient should take direct oral anticoagulants, such as apixaban, to prevent further DVTs. If the patient is pregnant, direct oral anticoagulants and warfarin are contraindicated, and she should take low molecular weight heparin. Let's discuss the treatment of pleural effusions. How do we manage these? For both transudative and exudative pleural effusions, you treat the underlying cause. For example, give diuretics in congestive heart failure or albumin in nephrotic syndrome or liver disease. Therapeutic thoracentesis is performed if the patient has a large pleural effusion that is symptomatic, including respiratory distress or failure, or hemodynamic instability. What is a complicated parapneumonic effusion And how do we treat it? This type of effusion most often occurs after bacterial pneumonia and involves bacteria in the pleural space. It is drained to prevent the formation of a pleural empyema, or pus in the pleural space, in addition to giving antibiotics. How do we treat pleural empyemas? Antibiotics are given to cover common organisms causing pneumonia, including strep species, Klebsiella, and Haemophilus, plus anaerobes. Regimens include ceftriaxone plus clindamycin or metronidazole if it's community acquired, with the addition of MRSA and Pseudomonas coverage if it's hospital acquired. Chest tube thoracostomy is performed to drain the empyema. Video-assisted thoracoscopic surgery may be necessary to remove material if the chest tube is ineffective. If the pleural linings of the lung become fibrosed, pleurectomy may have to be performed where the pleural linings are removed to help lung expansion via an open thoracotomy surgery. What are indications for pleurodesis, sealing of the pleural space? This is indicated for preventing recurrence of malignant pleural effusions. It's also used for stubborn, simple transidative effusions that don't respond to medications. How do we treat a hemothorax, or blood in the pleural space? Hemothorax is most commonly due to trauma, but can rarely be spontaneous, such as after a spontaneous pneumothorax. Initial management consists of a chest tube placement in the fifth intercostal space mid-axillary line. The hemothorax must be removed regardless of size, because the blood will clot and the lung will not be able to expand. What are indications for surgical intervention? After a chest tube is placed for hemothorax, urgent thoracotomy may be considered if some of the following occur. 1. Initial drainage of more than 1,500 milliliters of blood. 2. Continuous drainage of more than 200 mils of blood per hour for over 2 hours. 3. If the patient has a great vessel or chest wall injury. And 4. The patient develops pericardial tamponade. Let's discuss the treatment of a pneumothorax. Treatment depends on whether the pneumothorax is spontaneous or traumatic. What is the treatment for a spontaneous pneumothorax? Treatment will depend on whether the patient is stable or unstable and the size of the pneumothorax measured on X-ray. Stable patients have a normal blood pressure, heart rate under 120, respiratory rate under 24, and SpO2 over 90%. A small pneumothorax will resolve in under 2 weeks. If it begins enlarging on repeat X-ray, or is a large pneumothorax, place a chest tube. Needle aspiration can also be considered for a large pneumothorax. If the patient is unstable, he may have a tension pneumothorax or bilateral pneumothorax. For a tension pneumothorax, perform emergency decompression with needle thoracostomy in the second intercostal space, mid-clavicular line, or fourth or fifth intercostal space between the anterior and mid-axillary line, followed by a chest tube in the latter location. For bilateral pneumothorax or unilateral pneumothorax in unstable patients, emergent chest tube placement is indicated. How do we treat a traumatic pneumothorax? Similar to a spontaneous pneumothorax, if it is small and the patient is stable, it can be managed with observation. If the patient is hemodynamically unstable, the pneumothorax is large, or there is hemopneumothorax, of blood and air in the pleural space, a chest tube is placed in the fourth or fifth intercostal space. How do we treat an open pneumothorax, also known as a sucking chest wound? If the patient has an open pneumothorax, apply occlusive dressings taped around 3 out of 4 sides of the wound. This allows air to escape from the hole in the dressing during exhalation, while preventing the entry of air into the wound during inhalation. It prevents the development of a tension pneumothorax. Like recurrent pleural effusions, pleurodesis is indicated for preventing recurrent pneumothorax. Let's discuss the treatment of atelectasis, partial or complete collapse of a lung. There are many etiologies, but what is the most common cause, and how do we treat atelectasis? Atelectasis is most commonly caused by a mucus plug, often after surgery because of decreased coughing or deep breaths. In addition to anesthesia, treatment involves early mobilization and treating the underlying condition. Maneuvers that increase PEEP should also be performed to increase alveolar pressure and volume, such as deep breathing exercises and incentive spirometry. CPAP can also be used. Let's discuss the treatment of a lung abscess. What are the most common causative agents, and how do we treat it? The most common cause is a bacterial pyogenic lung abscess caused by anaerobic organisms in the oral cavity, often following aspiration. IV drug users may have hematogenous spread to the lungs, and this may involve Staph aureus. A staph lung abscess may also be the cause if the patient recently had an influenza infection. If the patient doesn't have any risk factors for MRSA, the abscess can be empirically treated with broad-spectrum antibiotics with anaerobic coverage, such as ampicillin sulbactam, clindamycin, ceftriaxone plus metronidazole, or carbapenem. If MRSA is suspected, linezolid or vancomycin can be used. Indications for bronchoscopic drainage or image-guided percutaneous drainage include large abscesses over 6 centimeters, an inadequate response to antibiotics, or hemoptysis. Thank you for joining us for the second of our 2 lectures on respiratory treatments. We hope you learned a lot. Additional notes on this topic will be available by following the link in the video. Take care.